Next, I'd like to reintroduce Dr. Nancy Phillips, who is an associate professor from the Rutgers Robert Wood Johnson Medical School, and she's going to speak to us on dyspareunia.
Hi again. My topic is going to be a little bit less of a catastrophe, although I think from speaking to the women who come in to see me, they think it's as much of, if not more of a catastrophe when they have dyspareunia. I have no disclosures to report. I will be talking about off-label and non-FDA approved medications through this talk.
Thank you.
So why are we talking about dyspareunia and menopause? Well, because they're talking about it. Because there are products, there are advertisements, and what was really scary to me looking at this slide reviewing yesterday was that we're actually closer to 2020 than we are to 2000. But life expectancy continues to go up, and those darn baby boomers, we've been hearing about them forever, and now here they are, we are. I'm not sure, I think I'm kind of on the cusp. But they're living longer, and they're healthy, and they're sexually active, and they want to have a good sex life, and they come to us for advice on that.
The adrenaline.
But they aren't always forthcoming. In asking for advice, although I find my patients are, maybe it's just because of the nature of my practice. But I think for a lot of people, before you can treat, you need to know. So you have to ask. And in reviewing some of my old slides before I put this lecture together, I noticed that I was always quoting studies about our poor history taking and how we were never asking about sex. And they were Dr. Bachman, who is my good friend and mentor, her studies from 1988, and Dr. Bassan, who, as you know, kind of rewrote the female sex cycle. She was the one who made it known that women did not necessarily have sex because of desire, but often had sex because of wanting to be closer, wanting the intimacy, because their husband wanted to. Was that voice? Is it just me hearing? Is it just me hearing voices? Or?
It's a previous speaker. I think she's still live.
Oh, okay. I've done that before.
Well, we had 7 deliveries that night, but we had a couple.
So Dr. Bassan's study was in 2003, and so I thought, okay, there's got to be more recent studies, and we've had to get better at this because we talk about it all the time. Found one study from 2011 of a patient perspective, and that was 1,500 women who said 90% of them wanted to talk about sexual functioning with their physicians or their healthcare provider, but only 40% had. So I said, maybe we're not getting that much better. And from a physician perspective, in 2012, 600 gynecologists, 63% routinely asked about sex. But then when they asked about sexual problems, it dropped down to 40%. And if they asked about sexual satisfaction, it dropped down to 30%. So we're still not doing as good of a job as we think we're doing, or at least I thought we were doing. I find it interesting that people routinely ask about sexual activity but don't ask if there's any sexual problems, because to me, that's like calling up and saying, you know, can I talk to your mother? And the person saying yes. And then, can you put her on the phone, right? To me, it just seems natural. Are you sexually active? You know, are you having any problems? It just seems like the natural next question, and I think we need to make it the natural next question. I'm not going to spend a lot of time on history taking. We all know how to take a history. When you're talking about sexual problems, again, how, when, where, with whom, how deep, how long. You need to know that. You need to ask for the gory details. Don't be embarrassed to ask. People want to talk about it for the most part. If they don't want to talk about it, they're not going to. But you need to ask the questions because that's how you can decide how to help them. Plus, your normal history, you need to know their medical history, their surgical history, what medications they're on. Again, we should always be asking about a history of any kind of abuse, past, current. And all those things play into sexual problems, and I don't know that I need to review all that for people to understand how that works. Menopausal dyspareunia. It's not always atrophy, is it? But a lot of the times it is atrophy. So we have to talk about it. Show of hands. You have atrophy figured out and you can handle it. Who says yes? Who says no? Who says mostly yes? I kind of fall into that mostly yes category. And the mostly yes category is the one that I'm going to talk about because most of the time we can handle atrophy. Let me go back. We can handle atrophy. Lubricants, estrogen, done. It's when lubricants and estrogen are not done that we have the problems, and that's what I want to focus on. So we all know that vulvovaginal atrophy is now called the genito-urinary syndrome of menopause because nothing can ever get easier or shorter. It always has to get harder and more complicated. All this basically says is it's a collection of symptoms. It's everything we always knew vulvovaginal atrophy was, but it's better defined. And they're making it a collection of all the possible symptoms that come from estrogen decrease, including genital symptoms, sexual symptoms, and urinary symptoms. Again, the key there is mostly related to, this is related to the decrease in estrogen. Physical exam. Look, we talked about that yesterday. You've got to look, right? A Q-tip test, or I'm sorry, that's a brand. A cotton swab test. Everybody knows what the cotton swab test is? I should have put a picture of it in here. I was thinking of it last night. I do this on every patient, irregardless of the vulvovaginal complaint. I have a very heavy Vulvodynia population, which is why I do this on everybody. If you're thinking of the introitus and you want to test the vestibule, right, which is the area right outside of the hymen, you've got to separate the labia. Take your cotton swab and you want to touch in the four positions, whatever o'clocks that would be. What would that be? 5 o'clock, 7 o'clock, 3 o'clock, yeah, whatever those o'clocks. You want to touch up periurethral on either side, kind of, I guess that would be 2 and 11, and then you want to touch more in the posterior with your cotton swab. Just a very gentle touch. And if they react to that with pain, that's a positive cotton swab test, which is the way you diagnose vulvodynia, but I think it's present in things other than vulvodynia as well. Vaginal pH, I get a vaginal pH on everybody, and if there's one thing that's going to be most helpful to you, it's probably the pH. And the microscope. And the microscope is important both for us in the office. I always think of the microscope in two terms. One, I want to look at what's going on in the vagina underneath the microscope. And if there's something going on the vulva that I don't know what it is, I want my pathologist to look at it underneath their microscope. So biopsy is a very big part of this. So typical vulvovaginal or GSM exam. Thin, pale skin, loss of rugae. The labia minora are kind of fusing to the labia majora, which have much less fatty pads into them. There can sometimes be fissuring in the posterior fourchette. What I find is with the severe vulvovaginal atrophies that there often is a positive cotton swab test. pH is going to be high. You're going to see scant squames, some white cells. You're going to not see any pathogens. So you're not going to see clue cells. You're not going to see yeast. And you're not going to see lactobacilli either. And that's very classic what you're going to see for vulvovaginal atrophy. Treatment of vulvovaginal atrophy, said it before. First line, moisturizers and lubricants. This is according to the North American Menopause Society. Second line is local estrogen therapy or Ospemifene. These are the 2013 position statement. So moisturizers and lubricants. This was going to be one of my catch box, so pretend I'm throwing the catch box out. Does anybody have a lubricant or moisturizer of choice that you tell women about? Okay, Replens, which is a moisturizer, right? What's the difference between lubricants and moisturizers? Lubricants are for an acute situation. You want a lubricant when you're going to have sexual activity, when you're going to have any form of vaginal activity. A moisturizer is more of a conditioning agent that you use on an ongoing basis. So think of a moisturizer the same way you would think of a hand cream. You want to put a hand cream on all the time to keep the skin healthy. So Replens is a moisturizer. This was kind of a little bit of a trick question. I'm not going to pull you guys into this because I was going to ask, you're going to name a moisturizer or a lubricant. Can you tell me if it's water-based, petroleum-based, oil-based, or silicone-based? Can you tell me if it has glycerin or if it doesn't have glycerin? Can you tell me if it has propylene glycol or parabens in it? And as the story I told yesterday, can you tell me where to get it? Can I buy it at the grocery store? Do I have to go to a pharmacy? Or do I have to order it online? And those are the kind of questions that you need to be able to answer in certain situations. Again, just like most of the time you can say, go get some KY, use the KY, go get some Astroglide, use some Astroglide, and you'll be fine. Or one of the other hundreds of lubricants out there. And I think that as gynecologists and healthcare providers for women, that every so often you have to, this is probably easier for the women than the men, and I apologize for this, but every so often you have to go down to your local pharmacy and spend about an hour or so in the lubricant aisle and just kind of look through them and read the boxes and get a little bit familiar with them. Or that's another search you can do online. Again, not in your office because you'll be blocked. I've been kicked out of my computer in my office. I can't tell you how many times. I'm probably on some kind of watch list somewhere. Oh, that's a good slide. Okay. Why do you need to know those different components of the lubricants? Well, propylene glycol can cause cell toxicity and can cause irritation. So sometimes the way people are trying to fix the problem can make the problem worse. Anything that's petroleum-based has been shown to cause a 2.2-fold increase in development of BV. Something that contains glycerin, now why do they put glycerin in? They put glycerin in for two reasons. Glycerin is very slippery, right? You use glycerin, you know what's a great use for glycerin if you have it around? Making snow globes. Water, a little bit of glycerin, some sparkle. Great snow globes. But it's kind of thick and it's slippery. But it's also increases colonization with Candida. Again, studies show that 44% of women who use glycerin-based will have Candida colonization versus 5%. And then the oil-based are not compatible with condoms. I forgot to fill it in last night. I was thinking of it actually this morning. Silicone-based, you can't use with silicone objects. So you don't want to use it with a diaphragm. You don't want to use it with a sex toy because the silicone-based lubricants will break down the silicone in the other products. And it will make fissures in them and increase their bacterial content. So you have to be careful with that. So you have to ask questions to know this. So somebody who says, I'm 74 and I won't order online, like my parents who will never put their credit card number online because they just know that they're going to get their identity stolen, you want to make sure she can buy hers in a grocery store. Somebody with yeast all the time, you want to make sure that they don't have glycerin. The other part of glycerin is sweeter tasting. So the ones that have no glycerin can be a little bit more bitter. Whenever I use a lubricant, I get irritated. You want to stay away from the ones with the propylene glycol and probably the parabens. I'm in a new relationship. I worry about STIs. You want to make sure that if they're using condoms, that you're not giving them something oil-based. Okay, so you kind of need to know your lubricants a little bit. The best thing to do is pick one or two favorites and have a list. Okay. I have added a list on there of some moisturizers and some lubricants. I'm not necessarily endorsing any of these. I have no stake in any of these. There's tons of them out there. You can do your own research. I tried to put a little bit of information in there. Many products have different formulations. There's Astroglide and Astroglide Free. There's System Joe, which also has been in the past called Joe Premium, that some of them are silicone-based, some of them are water-based. And you'll find that a lot of them have different formulations in that way. I generally tell people to stay away from the warming, the scented, the glow-in-the-dark, all those kind, because those tend to be more the more stuff that's in them, the more things they do, the more stuff that's in them. The more stuff that's in them, the more likely they are to be irritating as opposed to improving the situation. So if the first line doesn't work, or if you're in a practice like mine where by the time people have gotten to you, they've tried that, you're down to your second line, which are local estrogen products. I don't need to go over these. We all know them. We know that there are creams, that there are rings, and that there's the vaginal tablet. The only one that is FDA approved actually for the indication of dyspareunia is Premarin at a 0.5 milligram twice weekly dose. That's the only one FDA approved for dyspareunia. Ospemifene or Ospemifene is also approved for moderate to severe dyspareunia. It's an oral selective estrogen receptor modulator. It's a 60 milligram daily dose. Not only does it improve symptoms, but like the vaginal estrogen creams and some of the moisturizers, it will also improve the maturation index and the pH, making the mucosa more similar to a premenopausal mucosa. The side effects are hot flushes, which is a drawback. It does carry a clot risk because of the estrogen activity of it. It does not have any endometrial stimulation, which is a good thing. It is probably an anti-estrogen, probably protective in the breast, but there's no long-term data to show that as of yet. So you have to be a little cautious in it in terms of people with risks for breast. So that's the first line and the second line. What if you need a third line? Why doesn't estrogen or these local treatments, why don't they always work? They should always work. One, the patient's not using it. Two, you're giving them the wrong dose, which is usually too low of a dose. The wrong preparation, because they're kind of created equal, but not completely created equal. Or you're not using it enough. It's the wrong hormone, and we'll talk about that a little bit. Or atrophy was not the problem. So if you feel like 1, 2, and 3 up there have been satisfied, then you have to look at 4. So I'm going to go over 1, 2, and 3 first. Patients not using it. Number one reason people don't use it, cost, right? Unfortunately, Medicare doesn't cover any of the topical or local estrogen preparations. And that's a big percentage of your population who's using it. There are coupons. I always tell people to look online. They keep promising us that a generic estrogen is going to come out, although I don't know how close we are to that. After somebody gets relief, the initial relief, they can space it out so they can use it less frequently. And as one of my male partners told me, gotta love this guy, he said, just tell them to tell your husband for $200 a month they can start having sex again and they're gonna buy their estrogen. So that could work. The second reason people don't use it is fear. And that is our job to tell them that they shouldn't be fearful of it. I tell people, frankly, not to read the labels. I also tell them because of the very low absorption that even if there are risks, the risks are really small compared to taking it orally. I'm a big proponent of oral estrogen, so I can counsel them that way as well. You can give them very low dose preparations if that's what they're concerned of. Sometimes they use less of it as opposed to more. My line that always seems to hook them is we even give it to women who have had breast cancer. And that usually kind of turns the corner of that. And speaking of that, ACOG has finally come out just in March of 2016 and said that data does not show an increased risk of recurrence for women who use vaginal estrogen preparations who have had breast cancer. They do say that there may be a difference between women on tamoxifen, because remember tamoxifen is blocking the receptors, so we may be not doing so much of an effect to women on tamoxifen as women who are on aromatase inhibitors, because aromatase inhibitors, even a little bit of a bump in estrogen may make a difference. So you should never do this lightly. You should never do this without at least conferring with the oncologist. And it really does come down to a quality of life issue for a lot of these women who would choose the estrogen over the theoretical or low risk of recurrent breast cancer. Wrong dose, preparation, or frequency of use. The tablets and rings are the lower dose. They're the lowest doses. They take longer to work, so you have to be more patient with them. Even the creams, which are higher dose and you can use more of them, they take a good 4 to 6 to 8 weeks to really see an impact. If the insert is too painful, sometimes people aren't using it because it's too painful, then maybe the oral Ospemifene is the answer. If most of their pain is on insertion, don't forget to apply it externally. And I usually, if I give a vaginal cream, I tell them to put it externally every night and internally twice a week, so that they're getting a more rapid response to the external tissue. It eventually is going to hit the external tissue. It's just going to take a little bit longer. And I love this slide. Look at those doses. These are the FDA-approved doses for these creams. Estrace vaginal cream, 2 to 4 grams a day for 1 to 2 weeks. That's a lot of estrogen. So we're giving this little piddly 0.5 twice a week. What you want to do, I don't give 2 to 4 grams daily because that's going to give me systemic symptoms. And my clue to women is if you start having breast tenderness, then you're absorbing it. And if that doesn't bother me because I know that I'm not going to give them a high dose for a long time, but I'll usually start them on every other day or every day for a few weeks until I start tapering it down. But my cue to them that they're absorbing it is that they're starting to get breast tenderness. So if they are the women who are very afraid of the absorption, I tell them if they start getting breast tenderness to start backing it down sooner. And even the Vagifem tablet, it's 1 tablet a day for 2 weeks is supposed to be the initiation. And we hardly ever give those kind of doses. And what I find is often I have women referred into me and all I have to do is give them more of the estrogen, or they've tried it for 2 weeks and it hasn't worked and so they stop it. So you have room to play with the doses. Now this drawing makes sense in my head, which kind of is a little scary to me. This is what I'm trying to say. Maybe you're giving them the wrong hormone, and I do this a lot with Vulvodynia. Okay? That is supposed to be a vaginal, the vulva and the vagina. That's about as good as my artwork gets. But use my arm instead because I use my arm a lot. This is the entrance to the vagina. This is the introitus, and this is going up the vagina. Estrogen receptors. You get more and more and more estrogen receptors as you go up. You get more and more and more testosterone receptors as you go down. So what I find in really resistant vulvovaginal atrophy, and also in a lot of my Vulvodynia patients who have a lot of atrophy or have been on hormone therapy who have been on oral contraceptives for a long time, or who are menopausal, Often the estrogen is not enough, and I will add testosterone to that. And, I lost my beeper. Okay. Okay, so the testosterone that I use, you have to compound testosterone. That's my formula for compounding testosterone. I always combine it with an estrogen. And there are some pharmacies, some compounding pharmacies that don't like methyl cellulose, and they'll talk to you about which preparation they want to put it in. Applied externally twice a day for 12 weeks and then taper. I find a lot of women who never really taper less than once a day or a couple times a week. I get this formulation is from Dr. Goldstein, Andrew Goldstein, the Vulvodynia guy. I always mix up his first name because he has a brother who also does it, but I think it's Andrew, who does a lot of Vulvodynia, and this is his kind of formulation for Vulvodynia. I use this quite often. You need to know where to send people to get things compounded. I don't know if Walgreens is throughout the whole country, I'm sure. A lot of Walgreens will compound, but if not, there are specialty, they can Google, or you can Google compounding pharmacies. Some of them are mail away, but there are also lots of local ones. Yes?
Walgreens corporate office just cut all compound.
Did they really?
Yes.
Oh, that's going to be a problem. Oh no, okay, all right, well, scratch that last comment about Walgreens. Now I guess we're going to have to find compounding pharmacies.
Andrew. Andrew Goldstein.
Andrew Goldstein, thank you. Did I say Andrew? I think maybe I did. He has a brother, Stephen, I think. But anyway, I can never remember. So just like my little warning about absorbing estrogen is breast tenderness, because everybody's always so worried about testosterone side effects. Am I going to grow hair? Am I going to grow a beard? What's going to happen to me? Am I going to get muscles? Usually, if they're absorbing the testosterone, the first thing they're going to see is a little bit of acne. So I tell them if they start breaking out a little bit, then they can kind of go down a little bit on their testosterone doses. Okay? It works really well. The other one, which again is not FDA approved, is DHEA. DHEA is a prohormone, meaning that you give the DHEA, and the DHEA is actually metabolized locally, and it's metabolized into some estrogens, some testosterones, and very locally metabolized both into those hormones and very locally metabolized so that there's not a lot of absorption. And that actually also works very well. As well. There have been tons of studies on this DHEA, and again, just like the generic estrogens, we keep hearing that this DHEA is going to become available with the indication for atrophy and dyspareunia. I don't know how close that is, but it will be nice when we actually have a preparation for it. I put this in here. I've had several patients say to me, what about E4, the placental estrogen? I searched and searched and searched. I could not find anything about E4 or the placental estrogens. The only thing I could find was, again, just like you can take your placenta and you can make it into capsules, and you can take your placenta and do things like that. If people talk to you or ask you, I don't know if anybody has asked you guys about that, but I'm just mentioning it because it has been mentioned to me. I cannot find anything about it. Vaginal rejuvenation. Again, I probably should have added this into my talk yesterday when I was talking about sexual dysfunction as well. The first one was the Mona Lisa Touch, which is a fractional microablative laser. It's 1 to 3 treatments. They last 3 minutes each. They're about a month apart. You tend to need to repeat them probably about a yearly, is what estimated that you repeat the treatment about yearly. I found a couple studies about it, 77 patients, significant improvement in all of the domains of the female sexual function index. Again, that's arousal, desire, orgasm, and pain. So it improved all of those categories. It is FDA approved. It's FDA approved for the treatment of vulvovaginal atrophy. It works by stimulating collagen. So it's almost like when somebody has a dermabrasion of the face, right? You kind of scrape away or laser away or heat away all of the underlying skin or the old skin, and you stimulate some vascular growth, you stimulate some collagen growth, and then you grow a layer back that's better than the layer that was there before. Mona Lisa Touch was the first one. There is one called FemiLift now. There are no placebo-controlled studies. Any study I can find on any of these, there were not any placebo-controlled studies, but anecdotally, and they tend to work very well. Thermava, was that the one you mentioned to me yesterday? What was the one you mentioned yesterday? Thermiva. Thermava, Thermiva. You say tomato, it's tomato. It's not a laser, but it's based on radio wave technology. Again, 3 treatments. Has been associated with vaginal atrophy, tightening, improved sexual function, and also improvement in minor prolapse and some incontinence. I could find only one study on that. Again, no placebo control. I think we'll be seeing a lot more data on these treatments as over the next couple years. From having been at the recent ACOG meeting, every other booth seemed to be a new development of one of these vaginal rejuvenation products. I don't have any experience with it, I have to confess. I'm sure a lot of you do. Do a lot of you have experience with this? The machines are very expensive. You can lease them. None of this is it's kind of a cash business because it's considered, well, I don't know if it's because it's not insurance reimbursed. I work in a university which is also a state university, so 3 or 4 years from now we may be able to get one in. We're trying very hard to get one in, and we're also have been approaching different companies to do studies on them. There are a couple out there who have started doing some studies, actual sham studies, where they'll put the probe in, one will be active, one will not be active. So I think we're going to be seeing a lot more about these in the future. But they are a very good option. They have really good anecdotal outcomes. They're a good option for those breast cancer women who you really would prefer not to give estrogen to if you could get away with it, people who are resistant to some of the other treatments. So I think we're going to be seeing a lot more of these in the next coming years. So what's the last reason why the estrogens or these other hormones or these other treatments don't work is atrophy was not the problem. So look again. So we're going to look again. And this time we see slight erythema with no lesions. We have a very strongly positive Q-tip test or cotton swab test, a normal pH, and normal squames, no pathogens, and there's some lactobacilli around. Okay, so this is suggestive of my favorite, Vulvodynia. And just like you said, your patient is going to pay for your gray hair, my entire practice is going to pay for my rehab someday because I spend all day with vulvodynia, vaginitis, vaginismus, and sexual dysfunction and pelvic pain. Vulvodynia has a new classification. It was published simultaneously in several journals last year. The old part of the classification didn't change. It's basically vulvar pain, 3 months duration without a clear identifiable cause, and then it's broken down into localized, provoked, primary or secondary, and then the temporal pattern, intermittent, persistent, immediate, delayed. What is new is that they have added this whole list of potential factors associated with vulvodynia. In my mind, this is a very good clinical tool because it gives you a way to approach these women. It gives you something to look for. It talks about comorbidities, fibromyalgia, painful bladder. Talks about sometimes it could be genetics, which doesn't really help you clinically, but at least gives you something to tell the patient. Hormonal factors. It goes through the whole list. In my mind, I think if you can really identify one of these things, if I can find a real hormonal factor and treat the hormonal factor and it gets better, in my mind that's not vulvodynia anymore, that's now vulvovaginal atrophy, but it's a good differential. Vulvodynia, reining it in. Do you guys see a lot of vulvodynia patients? Some vulvodynia patients, even one vulvodynia patient is too many vulvodynia patients. I'm going to just tell you what I do, which in my mind it has to be simplified because it's so looks easy on paper, but it's so complicated when somebody's in front of you. Again, my hand, skin, muscle, nerve. Okay? Just remember that when you see a vulvodynia patient, skin, muscle, nerve. Try to determine on exam if one of them is more prominent than the other. In terms of skin, look for concomitant things. You know, people can have vulvodynia and lichen sclerosis. They can have vulvodynia and something else. Maximize the health of the skin is going to help. Because vulvodynia probably, in most cases, is a nerve disorder. The deeper you can get those nerves covered by healthy skin, the better you're going to be. So look at the skin. And if somebody is postmenopausal, lactation, has been on the combined oral contraceptives, again, remember they're dropping your testosterone, and where are those testosterone receptors? Then you want to replace that, okay? I always tell people estrogens or the estrogen estrogen testosterone combination, it's like hand cream for your vagina. You need it to keep that skin healthy. So always look at the skin. To check for the nerve, the cotton swab test is kind of a nerve test, right? But they're all going to have a positive cotton swab test. To look for the muscle, next time you do an exam on anybody, when you have your fingers posteriorly, move them laterally, move them up a little bit, and pull down like that. You can't normally feel those muscles, right? You don't think about it, but you don't feel those muscles. In somebody who has spasm or a muscular part to the vulvodynia, you're going to feel those muscles. You're going to put your hands laterally, you're going to pull down, and you're going to feel a bump where those muscles are. And if they're really tight, you're going to feel stringing, almost like a violin string. You can pluck it. People feel you pluck it. And you shouldn't have a violin string coming through your vagina. That means that you've been in a lot of spasm. So if you see, and I see vulvodynia people with tons of spasm, I see some with no spasm at all. Most people, I think, have a little bit of spasm. Okay? And I think that the vaginismus vulvodynia thing, it's kind of chicken egg. So treating both of them is often helpful. But if the skin looks good and I don't feel a lot of muscle, then I know that this is a nerve person. And the nerve people, oops, I'm out of order. Let me do it the other way. If I feel a lot of muscle and I've treated the skin, then I want to send them to pelvic floor physical therapy. Pelvic floor physical therapy works wonders because these physical therapists, not only are they great at massage, trigger point massage, they will give home exercises, they will give dilators, they do biofeedback. They're also great diagnosticians. I have sent several people to pelvic floor physical therapy where the physical therapist has called me and said, you know, she has a labral tear of her hip. And you fix her hip pathology and all of a sudden her vulva gets better. Remember all those muscles? Remember medical school, that muscle, all those muscles that you know and hate? Trying to remember all their names? You know, I tell people you feel a string, and then they go to the physical therapist, and they go, the lateral band of your piriformis, blah, 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 blah. And they can really differentiate it for you. If the physical therapy You have people who are so tense that they can't even do the physical therapy. You can give them some, and I hate to say it, is Dr. what's her name? No, she's not in the room. Okay, you can give them some Valium. Shh, don't tell anybody. You can give them Valium suppositories, which work as a really good muscle relaxant. Oh, she is in the room. I'm sorry. Suppository. You only give them a couple. You can also do baclofen. You can do topical baclofen or even oral baclofen. But to at least get somebody to be able to put their fingers in the vagina to start doing the therapy is helpful. Okay? If your skin is good, your muscle is good, or you're treating the muscle, then you're a nerve person. If you're a nerve person, then you're better off going right to gabapentin, right to the tricyclics. Okay? There are also, you can consider Lyrica. You can do Cymbalta, especially in those patients. You know, you have to think of the whole patient. If I have somebody who has also fibromyalgia, then I would consider doing Lyrica. If I have somebody who has interstitial cystitis, I'm going to go more to the tricyclics. So you're trying to get the most bang for your buck there. So you have to look at the whole thing, but hopefully that will give you a start point. Start at really low doses. Okay, you know, tricyclics start at 10 milligrams at night. They also help people sleep. I find that if you get to 40 milligrams of any of the tricyclics and they're not working, they're probably not going to work at a dose that somebody can tolerate because they really are sedating. Gabapentin, we did a study that we just are compiling the results, a placebo-controlled gabapentin study, where we went rapidly up to 3 grams, 3,000 of gabapentin. When I start patients, I usually start them, depending on their age and their health and other things, I start them on either 100 or 300. And I have very few patients who are over about 1,200 milligrams. Gabapentin always sounds scary to people because it's an anti-seizure drug. It's actually really well tolerated. I find it has less side effects than the tricyclics. The biggest side effect is usually sleepy. So take it at night, or put the bulk of the dose at night, and then you can split the rest of it during the day. I combine a lot of these therapies. I have to say I have probably 80% of my Vulvodynia patients also going for pelvic floor physical therapy because it really does help. If they don't want to go to physical therapy, their insurance doesn't cover it, they don't have time, I will recommend some of the exercises to them, a set of dilators with instructions how to use the dilators. Don't forget about topical lidocaine, which works wonders but burns, so make sure that they take the topical lidocaine and they mix it with something that's non-irritating, kind of a half and half strength. And they can put that on 20 minutes prior to any sexual activity or any contact, or they can use it as the lubricant beforehand and with the dilators. Also, don't just tell people to buy dilators. You need to know where to get them, how to get them. Again, I'm not endorsing this product. I have no stake in this product, but there's a website called Vaginosis.com, and they actually sell a nice set of dilators. What I like about these dilators is they start small. Some of the dilator sets, they start too big for patients and they get too huge for most people. This set starts small, and it also has a handle that you can put it into a handle as opposed to just being the dilator, so you can actually snap it into the handle so that I think it gives a little bit of better control for patients. It's Vaginosis.com, $49.95, delivered in a brown box. Okay, so we have a couple more minutes. So atrophy, the last two were kind of more quick. Atrophy, not the problem. Vulvodynia, not the problem. Look again. Thin, pale skin, decreased labia, some fusion, white plaques. Q-tip negative, pH kind of borderline, and kind of a nondescript. pH 5, scant squames, some white cells, absence pathogens, absence of lactobacilli, which is not an atypical appearance. However, this is a patient of mine. This is what I saw when I actually opened and spread. What do you think? Yeah, this is actually lichen sclerosis. It's a fairly advanced case of lichen sclerosis, and I have to say that in this patient, this site right there is the site of one of my prior biopsies. I biopsy a lot. We should all biopsy a lot, especially when we see things like this, because this could very easily be VIN. This can very easily it could very easily be a vulvar cancer. So you need to biopsy these things. This was biopsied and it was lichen sclerosis. I have circled there dermatopathologist. Know your pathologist. Probably about a year and a half ago, I got tired of all of my vulvar biopsies coming back nonspecific inflammation. And I couldn't do anything with nonspecific inflammation. It was great because I knew that it wasn't cancer, which is ultimately what I wanted to know. But it wasn't helping me a heck of a lot. Although, in retrospect, knowing which exactly disorder it is doesn't matter too much because you give them all clobetasol. But it'd be nice academically to know the difference. So I got in touch with the dermatopathologist at the hospital. And again, because of insurance, because of transport, because of all those things, it's not quite as easy as it sounds, but started sending all of my biopsies to her. And now I, one, have somebody I can communicate with, two, have somebody who I can walk over and show these clinical pictures to, and three, a report that will actually say, this looks like it may be early lichen sclerosis, however, I can't rule out lichen planus, blah, 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 as opposed to nonspecific inflammation. And it really is helpful. So I do think it's worth knowing your pathologist and really interacting with them. One of these days, or when I get a medical student, I don't know what the point of this would be, which is probably why I wouldn't do it, but I would love to pull my biopsy results from the 2 years prior and the 2 years after and just do a comparison. Although I'm not really quite sure what I would do with that because I don't really want to publish something that says, yeah, look at these horrible pathologists. So I don't know what I would do, but I do think it would turn out to be better reports. Treatment for lichen sclerosis, topical clobetasol, low dose. Ointments are always better than creams. Creams tend to be more irritating. Once or twice a day for 3 months, and then taper. What I find with the patients referred to me with lichen sclerosis that is not responding, the vast majority of them use the 3 months of clobetasol and then stop because they have been told time and time again, you can't keep using the steroid because you're going to it's going to make the problem worse. The skin is going to be thinner. You're going to get into more trouble. That's not particularly true on the labia. For some reason, the labia are relatively resistant to the steroids. So you can use steroids ongoing on the labia. Clobetasol is a little heavy-handed, so once it's under control, you can change it over to just a hydrocortisone, or you can have them use it twice a week. But it has to be an ongoing treatment because this is a chronic disorder. My colorectal friends, we have a pelvic floor clinic, and in our pelvic floor clinic, we have a colorectal surgeon who screams at me to make sure my patients never get those steroids down around the perirectal area because it does thin the skin there. So use a mirror, show them where to put it, or you'll get yelled at. Again, resistance to the side effects. Second line is some of the, I can't pronounce any of these words, but tacrolimus. Applied once or twice daily. That's one of those really scary drugs that say if you use it for too long, you can get a lymphoma. So I'm a little worried about that one, but it really, from my dermatology friends who I talk to, they really do use it with a lot less fear than I use it with, and I do use it often. In the patient like I showed you where you saw those really thick white plaques, you can also do intralesional injections with triamcinolone. To try to get some of the really thicker plaques resolved. By the way, this patient that I showed you, she has a history of systemic aspergillosis and was told never to use steroids in any form ever again. So despite talking to her ID person, despite going over this ad nauseum, she is basically refusing any treatment. So what I'm doing for her is just following her every 6 months, and I think eventually all the biopsies I do will probably resolve all of her lichen sclerosis. Her ID physician did give us the blessing of using hydrocortisone. However, I suspect she's not using any of it because I think once you've had systemic aspergillosis and you've had neurological things and seizures from it, it's probably a scary thing. But anyway, one last one that I don't think I'll spend too much time on because I didn't realize there was going to be a vaginitis lecture as well. But again, I'm just going to touch base. Erythema, gray discharge, high pH, clue cells, and no lactobacilli. So what do we have there? Our friend BV, right? We love BV. It never goes away. It keeps us in business. Menopause is just a setup for BV, right? You lose your lactobacilli and you increase your pH. So what's interesting is in menopause you can have women who have BV with BV symptoms. And those symptoms are going to be the same symptoms like everybody else has: odor, discharge, dyspareunia. You can also have BV appearing flora without BV symptoms. And what's interesting is that this may be an underlying cause, I'm not sure if atrophy is the right word, but an underlying cause of symptoms of atrophy, even if you don't have symptomatic BV. BV increases with age. This was an interesting study where they followed women between 57 and 87, 1,000 women. They swabbed them at year 1 and year 5. And what they found was that the incidence of BV increased with increasing age. And if you had it at year 1, that you had a relative risk, a 10 times relative risk of having it again at year 5. And if you had it an intermediate risk, you had a relative risk 5 times of having it at year 5. So there are definitely, it went from 23% of women at year 1 to 38% of women at year 5, and regardless of their age, they were older 5 years later, so kind of inferred that it got increased with age. But it also showed that once you're kind of at risk or have BV, you're kind of always at risk for having BV. And again, that's why it can be so frustrating to patients, frustrating to us as well, because we're constantly trying to fix BV. Treatment of BV in menopause is really the treatment of recurrent BV, because you don't just treat once and fix it. Sometimes you do, and that's really great, but most of the times you don't. So the same kind of treatment that you would normally use: Metrogel, metronidazole, orally, initial treatment as per usual, also clindamycin. I'm sorry, I put clindamycin as a second line because I don't know, it doesn't have to be a second line. You can put that as a first line. Certainly boric acid. I don't know how many of you use boric acid. Love boric acid, and I should have put the dose on there: 600 milligrams in a 0 gelatin capsule. Important to tell people that boric acid is poisonous if taken orally, but it's okay vaginally. I always tell people to make sure they keep it out of the reach of children and pets, and that if they're using it, to please don't have oral sex, because then they can slowly poison their partner. Trying not to plant any ideas, but I do feel I have to warn them. And then suppression. You can use, I'm sorry, I'm using brand names here. I'm really bad at that. Metrogel, 1 applicator once or twice weekly for 8 to 12 weeks. Clindamycin is not recommended for suppression because of the risks of C. diff. Boric acid suppression, there's no long-term data, but I have quite a few people who just keep a supply of boric acid suppositories or capsules around. Sometimes I have them use it once a week, twice a week for prolonged periods of time. Sometimes as soon as they start to see symptoms, they just give themselves another, like a 5-day short course. The initial course is 14 days. Don't forget the pH. Again, you want to correct that pH. Estrogens if you can. This is where you look for the vaginal moisturizers, the one that have the pH that is low. Vinegar washes. Sometimes I tell people, I don't like people to douche, although I do tell people to douche. And when I do, I tell them to mix their own. Don't buy any of the betadine, scented, any of that kind of stuff. 1 or 2 tablespoons of vinegar and about a liter of water. I also tell them in the shower, don't use soaps, to take a little squirt bottle, again, vinegar and water, and just rinse the area using the little vinegar squirt bottle. And then the other thing I was going to touch on, do I have like 2 minutes? 2 minutes, I'm going to touch on the microbiome. That's the new buzzword, right? It's the new buzzword everywhere. Everything has a microbiome now. And I have to admit, yesterday I went over to the other room for the probiotics lecture because I thought I was going to learn everything about probiotics, but what I learned was I know as much about probiotics as anybody, which is not a lot. Evidence of menopausal change in the microbiome. There's been a lot of work done on this recently, and they've identified 6 community state types of microbiomes, or CSTs, that live in the vagina. 4 of them are lactobacillus dominant. 2 of them are low lactobacillus, and surprise, surprise, the low lactobacillus ones are the postmenopausal women. They're also different lactobacillus. And the lactobacillus dominated strains postmenopausally become a predominance of more anaerobic organisms. How does that help us? Well, we want to try to get it back to more lactobacillus dominant microbiome. And again, an inverse correlation between lactobacillus ratio and dryness. So the drier you are, the less lactobacilli you have. The less lactobacilli you have, the more prone you are to things like BV. How do we fix the microbiome? Estrogen, we correct the pH, we're going to help the microbiome, right? Probiotics, again, in that lecture yesterday, I was hoping he was going to say, this is the probiotic that everybody should be on, but that wasn't the answer, and I think it's because we don't have that answer. I think of that eventually, just like we do fecal transplants, we're going to be doing vaginal discharge transplants, and I think that is probably the best way that's going to ever fix the microbiomes. Evidenced by BV is very contagious, very transmittable between women. So in same-sex female partners, it's very transmittable, and that's been proven by a series of studies that would never get IRB approval anytime soon. But there's a Nobel Prize in it for anybody who can tell us which probiotic is going to fix all these problems. And then I just put a little bit, this is my very limited knowledge about probiotics. They're measured in colony-forming units. You usually need thousands to millions to billions. It should always say on the bottle, viable through the end of shelf life. They're available orally and vaginally. There are not good studies to tell which one is better. But you should look for those that contain lactobacillus or bifido or whatever, bifidobacterium. Those are the agents you want to repopulate in the vagina. And those that are listed there are the ones best studied for vaginal infection. The 2009 Cochrane Review, I'm sure there should be a one more recent or one coming up. Insufficient evidence to recommend for or against. I always recommend for. What I learned in the lecture yesterday was the best probiotic is the one you can afford to take. So whether Femdophilus is one that comes up in many of the vulvovaginal conferences that I go to, kefir, which is the drink, the yogurt drink, or any yogurt, but you have to have about 3 cups of it a day. I do recommend probiotics. I do think they're good. I do think there's going to be a place for them. I just don't think I can give you any more solid recommendations than that. Thank you. I'm sorry I went over.